For session 4, we'll have clinical demonstration on examining joints for joint counts and calculating RA disease activity. I request Dr. Dharmanand BG to brief about the demonstration. So we'll be dividing the audience into 3 groups.
Yeah, before we move, I give you a brief introduction what we are going to do in this last 10-15 minutes of the day today. So in rheumatology or in rheumatoid arthritis, why should we measure something? We know that it is rheumatoid arthritis, we know that patients come and tell that they are better. Why should we measure? What do we measure and how do we measure? Rheumatoid arthritis is a complex disease, as you all know. There is no simple or easy disease activity marker. Vis-a-vis HbA1c for diabetes, blood pressure is enough for a hypertension monitoring, and also monitoring your LDL may be enough to monitor your hyperlipidemia. So we don't have a single feature. There can be a patient who have normal ESR, very active arthritis. Some people can have a very high ESR or moderately high ESR, but arthritis would be normal. So a single marker is not enough to monitor these patients, and we need to document improvement. Arvind Chopra had presented a case who was coming to him regularly. They were monitoring. The patient was telling, "I am okay, doctor. I am doing well. I am doing well." In the notes also we continued that patient doing better. Patient is better. But end of 5-6 years, the hand would have got twisted, and the patient would have developed erosions and deformities. So just documenting that, asking for the question, "How are you doing this time?" They will say yes for various reasons. Sometimes they don't want an increased drug, because many patients are scared, dead scared of drugs, thanks to lot of factors. Their family doctor, somebody would have terrified them, "You are taking a toxic drug." So they don't want more drug. They say, "I am alright, doctor." So that's maybe one of the reasons. Second reason is they don't want to displease me, so they will say, "I am okay, doctor." So many times we continue the drug. So this may not be enough. And earlier days we did not have much drugs. Before methotrexate era, we could only palliate the patients. Now remission is definitely a possible entity. So we need to measure and show improvement and document improvement. So if a diabetic patient, if say your HbA1c is 9 last time, this time is 7.2, patients are happy that some number is improving. So this is the reason the measuring is important. What do we measure? I'll brief about few things. American College of Rheumatology has got a core set of measurements which are used predominantly in the clinical trials. And DAS28, so many people are talking about DAS28, again I will talk to you. Simple disease activity index, clinical disease activity index, health assessment questionnaire which also can be scored. There is something called RAPID3, which is a patient, we ask the patient to fill up a functional assessment score, a couple of questions based on which a score could be derived. And we ask the patient, "How are you doing?" on a scale of 1 to 100, and we give our assessment. These 3 is enough many times to assess the patients in the long run. That is the principle behind RAPID3. This is a template which is provided to you. This is a template used for DAS28 measurement. If you have noticed, there are 28 joints here, scored for swollen joints, tender joints, which is left side and right side. So end of the day you will know how many joints are swollen, how many joints are tender. And also ask a question, how active was your arthritis during the last 1 week on a scale of 0 to 10, or you can use 100 also. So if the patient is supposed to mark somewhere here, and depending upon the length of it, it could be 60 or 7 out of 10 or 60 out of 70 out of 100. So in this DAS activity score, it is always measured at 100. So it's 0 to 100 millimeter it is. And we use your ESR. You can also use CRP as a alternate. So we either calculate DAS28 based on ESR measurement or DAS28 based on CRP. So how DAS28 is calculated based upon a very complex calculation which we cannot do in the clinic, but there are quite a few online calculators and also downloadable Excel sheet calculator. Just enter the value, tender joint, swollen joint, ESR, and whatever patient scores 0 to 100.
You got an app also?
You got an app. So we can always use this to enter and derive at the You can download the app and you can keep it on your laptop, you can keep it on your computer desktop. There is a DAS site available where they have downloadable apps. This is another way of documenting it. So DAS, originally when they developed DAS, disease activity score, they were scoring actually 44 joints, swollen and tender joints. Then subsequently lot of complaints, they have still have to count lot of joints. So they have reduced to DAS 28, counting 28 joints, which is quite quick, can be done within few minutes. So that was found to be equivalent to counting 44 joints. So either we can use an ESR or CRP, as I told you. There are criteria. If a DAS score less than 1.6 is remission, when it comes to DAS 28, 2.6 is considered as remission. And also when we treat the patient, also we can assess whether the patients are getting better with our treatment or not. So if assume that our baseline DAS 28 score is say 6.8, if there is more than 1.2 decrease, then we know that the response was good. Anything between 0.6 to 1.2 is a moderate response. If the patient responds only by 0.6, we know that the patient has not responded. And also we can categorize the patient as highly active, moderately active, or doing very well based upon the score. Anybody who has got less than 3.2 score is in a low disease activity state. 3.2 to 5.1 is a moderate disease activity state. More than 5.1 is a severely active disease. So the DAS 28 scoring system helps us to place the patient even at the first visit into a category of mildly active, moderately active, or severely active. And this, if when you do it serially, it helps us to see whether the patient is improving based on our treatment. You do a baseline at 0, again at 3 months. If the score moves to 1.2, from 6.2 to if it has come down to say 5 point, it comes to 5, then it is 1.2 improvement. The significant improvement is there, so we can continue with the treatment and the strategy can be continued. There are other, to circumvent the need for calculators, there are simple disease active index developed. It calculates again same 28 tender joints, same 28 swollen joints. This is MDGA, is physician global assessment. A physician is supposed to assess the disease activity of the patient based on few parameters which we have at our hand: the history, the difficulty he faces with his day-to-day life, early morning stiffness, and also the ESR and CRP which is with us. Based on that, okay, we have to give a score between 0 to 10. And we ask the patient to rate their own illness. This is the most difficult part. At least objectively, as a doctors, we are trained to give a score to an illness based on looking at composite index. For the patient to give a score to their illness, most of our Indian patients do struggle. This is one area we have lot of difficulty in getting the information. They always say, "Neeve hakoli sir, neeve on score haki." They don't want to do that, and they also have difficulty. They say, compared to last time, I am 80% better. We are not interested in that. We wanted them to give a score for the disease activity on that day on a scale of 0 to 10. 0 is absolutely normalcy, 10 is bedridden state. So we want to ask them to rate, but many times patients do find it difficult to answer this question, but the youngsters are very quick. They say 80. Without even winking, a software guy will say 860 or 70, because in their mind they are ranking everything, rating everything, because even go to a food on a scale of 0 to 10, cleanliness 9, the behavior of the server 8, they are used to giving that score, but our Rangammas and Subbamas from Davangere, they are not able to do it. They find it difficult to conceptualize because they have never used to give a mark to anything in their life. So this is a difficulty, but we still try. With the CRP, it becomes simple disease active index. Just calculate. You see 28 joints can be 10, 10, we give say 6, it becomes 26, patient gives another 6, it becomes 32, CRP is 1, you get at the score. You might take away the CRP, it becomes a clinical disease activity index. These are all very simple indexes, provided we can get this easily. And again, there is a cutoff. Anybody has got score less than 3.3, they are in remission, and 2.8 for CDI, they can be considered to be in remission. I told you about American College of Rheumatology core set. They have a tender joint count. Initial statements are 28 or more joints, but usually most of the clinical trials they calculate 66/68. Hip is the only joint, it is scored only for pain. Rest of joints for 68 joints for tenderness, 66 joints for swelling. That is what is generally done in most of the clinical trials using ACR criteria. Swollen joint is counted. Patient assessment for pain. This is just pain. Visual analog scale for pain. How much pain you have in the last 1 week. And patient disease global assessment for disease activity. So we have to ask patient 2 questions. It is still more difficult. Ask them to rate the pain on a scale of 0 to 10. Then after them to stop, pause. How would you assess the same disease on a scale of 1 to 10? Patients find it difficult, this particular 2 things, but we do try in patients who are educated and able to comprehend. Again, physician global assessment, and patient's assessment of function is done with HAQ. The HAQ is a separate scoring system. If you do X number of questions, depending on whether you are able to take bath properly, you are able to pick up something, there are 10 questions, you just give a mark and you get a composite score. And of course, acute phase reactant is ESR or a CRP. So the improvement, 20% improvement in tender joint and swollen joint is required, and 3 out of other 5. If they have 20% improvement, we know that from the baseline, the patient has got improved to X number level. That means 20% improvement from baseline. ACR calculates serially. They don't have, there is no baseline ACR score. Only after the first visit you know that from the baseline you have improved 20%, either improved 50%, improved 70%. So for that reason it is done predominantly in clinical research and drug research. In the clinic we use the DAS28 scoring or complex simple clinical disease activity indexes. These are the 66 joints which are generally done. This is another way of documenting it. You can have a homunculus for tender joint, homunculus for just mark as we examine, just put a into the joints and count it end of the day, and you have a tenderous swollen joint count and a tender joint count, and we put it here. It is useful for the statistician to extract this information from your case sheet. So which are all the 66 joints which are generally calculated? These are all the joints: temporomandibular joint, sternoclavicular joint, acromioclavicular joints. There are so many joints. There are many indices. If you have noticed, 28 joint we calculate only shoulder, elbow, wrist, MCPs, 10 MCPs and 10 PIPs and knee joints. So this is very quick. Only PIPs, MCPs, wrist, elbow, shoulder and knees. So we can do this DAS28 very fast. This is a picture to demonstrate how a MCP is palpated. This is how a picture how PIP is palpated.
To evaluate the wrist, visualize
this is a short video which shows
the wrist
examination of the wrist.
Head, to the side of the radius and to the side of the ulna, feeling for the thickness of synovial thickening. Is that tender? Okay, the wrist is tender, so we would record that as being tender without necessarily putting it through its range of motion. If it was not tender, we would then flex and extend the wrist and then rotate it from side to side to see if we could elicit any additional tenderness. I'm now going to demonstrate
only one joint I'll show
joints. These joints are palpated individually. Again, they have to be palpated. You can't assume that because they look enlarged that they are swollen. That may simply reflect some subluxation. We're going to palpate from the sides, and if that's not tender, we'll palpate from the top and bottom also. If that's not tender, then we will put the metacarpophalangeal joint through a range of motion to see if it's tender. The same. So
this is just to give you a glimpse of how a joint examination is done. In the next 10-15 minutes, we will probably you all divide your 3 equal groups, where myself, Dr. Chandrasekhar and Shankar would demonstrate on a patient, no? On 3 patients, how we perform the 66 joint. We demonstrate all 66 joints for just for you to know how to examine a joint, how we examine a joint. But for practical purposes, we use DAS28. We calculate only 28 joints in the clinic for the scoring purpose. Of course, we do examine all the symptomatic joints in the clinic. So please divide yourself into 3 groups.
Audience, please divide equally into 3 groups. In all the groups, there will be clinical demonstration.